Good afternoon. We're so pleased that you're able to join us this afternoon for a really special time talking about really deep compassion and connection to people who have lost the ability to connect in the ways that are most common for the rest of us. We have some wonderful guests this afternoon that I know you're going to enjoy, and we're all going to learn from one another. We welcome you. My name is Patty Mouton. I serve as Vice President for Outreach and Advocacy at Alzheimer's Orange County, and I'm very pleased to be part of the palliative care team at Hoag, working on community education for end-of-life and advanced care planning. Our guests this afternoon are Dr. Dung Trinh. Dr. Trinh is a geriatrician. He is with the Memorial Care System, and he works in dementia research with Irvine Clinical Research. He has a wealth of knowledge about caring for older adults, especially those with dementia, and he's very active in medical missionary work as well as nose ring cells. He's eclectic in that department. Dr. Vincent Nguyen is also a pediatrician and palliative care physician. He directs the Hoag Palliative Care Program. He has been a fixture in end-of-life care in Orange County for more than 20 years and has directed the Orange County Post Coalition Advanced Care Planning Partners since 2009. And our last guest is Mona El-Kurd Mansour. Mona is a medical social worker, and she's been a colleague of mine for about 20 years. She's been working in hospice and palliative care for 30 years. And after leaving Canada, after earning her Bachelor of Psychology, she received a social work master's degree from the University of Windsor, and she's been on staff at Hoag since 2010. She has a wealth of knowledge, experience, and a palliative care fellowship from New York University as well. Currently, she provides outpatient counseling, advanced care planning, and helps to keep people connected to community resources, particularly about end-of-life care. She completed the Zelda Foster Leadership Fellowship at NYU in 2017. So please welcome our three luminary palliative care guests this afternoon. For those of you that have questions of our guests, if you type them into the question box, I'll be able to see them, and we'll keep this very conversational and a little bit informal, because we really want to have an exchange of ideas, and I think it's really going to be valuable for you to be able to see inside and really plumb the depths of compassion that our guests have experienced, how they use that compassion, and how we learn from it with each patient for whom we provide care and loving support. Our purpose today is to explore how best to connect with people who are near life's end, especially when they can no longer respond well to us. And in preparation for this, one of the books that I read that I highly, highly recommend is by Dr. Sam Fazio, The Enduring Self in People with Alzheimer's. Dr. Fazio talks about the fact that even though people cannot respond the same way, even though they have lost perhaps their verbal skills or even their ability to respond in classic ways, the enduring self remains. And no matter how much is lost, there's still quite a bit of brain and brain activity that remains, and the essence of the person remains. It becomes our job then to find ways to elicit some response and to be sure that we are prospectively and proactively seeking to meet the needs of the person who cannot tell us what they need. So Dr. Nguyen is going to discuss the World Health Organization palliative care definition and how we should be really moving upstream for people with serious dementias, this chronic brain failure. Dr. Nguyen, talk to us a little bit about how we should be framing end-stage dementia vis-a-vis palliative care.
Sure. Thank you very much, Patty. And I'd like to welcome everyone, and thank you so much for putting together this wonderful webinar. And just want to So I just want to start off by just discussing what dementia is. And for those who already know what dementia is, I just want to set the background for our discussion for the rest of the afternoon. So dementia, we know, is a cognitive, behavioral, and functional disease. And so what we mean by that, it's characterized by a deterioration in the person's cognition, which results in behavior problems and leading to difficulty performing the basic activities of daily life. So it's really those three things: cognitive, behavioral, and functional decline. And so when we talk about decline here, is the person loses their ability as the disease progresses, in which you know that there is this disease is very life-limiting, it's progressive, and it's incurable. And it takes away the person's ability to do things for themselves, such as things that we take for granted, such as dressing ourselves, being able to eat, to ambulate, to transfer to the toilet, and take care of our own hygiene. And it's also made up of a very complex neuropsychiatric disorder and can be described as we call chronic brain failure. And we know that with these type of brain failure, especially in Alzheimer's, dementia, and is that person loses their ability to communicate. It significantly impairs their ability to communicate. And this suffering too is not only this disease causes significant suffering for both the patient and the caregiver. From my perspective, though, is the suffering of patients is not a function of the disease itself, but it is a function of inadequate medical and nursing care. And I'm sure Dr. Trin can speak to this as a geriatrician, as we both are. We recognize that, this disease affects the entire person, the personhood, but it also extends it to an entire family and the caregiver. And the reason why I find this to be so impactful of what we do today is to provide caregiver education, providing, these are the people who's providing direct care, but you also need to have the tool to provide these appropriate interventions. And we know that when the caregivers are providing the support, it also helps to decrease their stress and improve their quality of life. And so as we talk about the dementia as a progressive disease, let's talk about how people in the United States, how do people with dementia die? Here are the three things. So this was published back in 2004, and it's been reiterated as well as in our own experience, is that people die with dementia, they die with inadequate pain control. They typically die with a feeding tube in place, and they die without the benefit of receiving palliative or hospice care. So it's really important to understand what palliative care is and how is that different from hospice, and how is that really different from end of life? Because oftentimes when people hear palliative care, they shun it. They say, no, that's the death squad, or it must be end of life, it must be hospice. But if we look at palliative care, it's defined as it is a specialty of medical care. It's specialized medical care for people living with serious illness. We're dealing with people not the last moment or last seconds of their life, but people living with the serious illness of dementia. The care is focused on providing the patient with relief of their symptoms. Most of the symptoms are, we said, pain controls are oftentimes inadequately addressed. And there's also the stress of not having your pain well controlled. The people holler, they scream, and it's very distressful for caregivers. And the goal of palliative care is to improve the quality of life for not only for the patient, but also for the family or the caregiver. And the beauty of palliative care, it takes the entire team of nurses, doctors, social workers, and other specialists working together to provide this extra support for family. And this care is appropriate at any age, in any stage of a serious illness, and can be provided with curative treatment intent. And we also know that with palliative care involvement, we have seen a change in the person's prognosis. Oftentimes the doctors say this person may have a few weeks for a few months left of life, but having additional layer of support, it actually changes their quality of life, and they may extend their prognosis. So with that said, I just want to utilize this as a framework for us to build upon, and then maybe we'll talk more about what some of the tools that we use to address pain and symptom management. So thank you for allowing me to set that foundation for us.
Thank you, Dr. Nguyen. We know that dying with dementia is different from other disease processes. We know that we have to have more refined toolkits, and that as professionals, we have a really serious responsibility to be able to train family caregivers to understand what things they can do from both a theoretical and a practical perspective. So, Dr. Trin, tell us a little bit about how you would help a family understand what's happening as a person enters end stage and maybe becomes hospice appropriate with a dementia diagnosis.
Definitely. I think from the years of seeing patients go through this entire process from beginning to end, I've been in medicine and in primary care for close to 20 years, actually, prior to going on to teaching and public education and things of that sort. But in the years of seeing my own patients go through the entire spectrum where they're completely normal, healthy, driving in on their own, and watching the slow decline over time, what I normally see is I see an interaction with a patient and their family member. And, and usually it's a spouse who is involved, or sometimes a child who is involved. And I see slow behavioral and emotional changes in our patients over time. And what we see often that goes along with dementia in general and Alzheimer's specifically is we see symptoms of frustration, of anger, losing your temper really easily, agitation. And I want to teach you a little bit on why our patients feel that way, why they go through this phase where they are now upset and easily angered and agitated. And these could be patients who, for the previous 60, 70 years, they have been the most gentle, the most nicest person, right, around. And now all of a sudden they're agitated. And why is this happening? And these are the same questions that their family members ask their loved ones. What's going on with my loved one with their behavioral changes? And to understand that, I want to give you a little bit of science behind Alzheimer's and the way that our brain and the brain of a patient with Alzheimer's store memory. So how does the brain store memory is the question. I want you to think of a computer hard drive, right? Like we're working on the computer on our laptop, and if we want to save a file, we click the save button, and that file gets saved right in the hard drive. So your brain is like a huge hard drive, and each memory is saved like a file. Okay, I want you to think about that. Just like a computer, each memory is a file. And the way your brain saves memory is that the oldest file gets saved first. The oldest file gets saved first when you're young, right? And then as you got older, the next file gets saved next to that. So there's junior high, there's high school, there's college, there's dating, there's weddings, there's children, and then there's grandchildren. And so one big long file of memories where the newest memory is over here and the oldest memory is over here. Okay, one long file, new memory here, old memory here. Have you heard about the Alzheimer's plaque? Right, most of us have heard about this plaque that builds up in our brain that's been associated with Alzheimer's. We call it amyloid. There's also tau proteins and tangles and things of that sort. But I want you to imagine that this plaque builds up over time in the brains of those with Alzheimer's. It actually takes 15 to 20 years of plaque buildup before it even causes any problem, right? Before your first memory issues. There's years and years of plaque buildup. When the Alzheimer's plaque attacks in this long file of memory, it attacks from this side first, where it takes away the short-term memory, the immediate memory, what you ate 5 minutes ago, what you had for breakfast this morning, right? Those memories go first. So short-term memory goes away initially with Alzheimer's. And as this plaque continues to chomp away, it eats in one direction, right? Where initially you don't remember what you did 5 minutes ago, and then over time, as dementia progresses, you don't remember what you did yesterday, and then you don't remember what you did last week, last month, last year, right? So these files, these memory files are being eaten away over time as Alzheimer's progress. And what happens is at some point, maybe a file of a funeral disappears. And now our patient, right, our Alzheimer's patient, no longer has a memory of a funeral. So that person is still alive. Have you ever witnessed a person with dementia talk about folks who are dead as if they're still alive? And it's not because they're crazy, it's not because they're not making sense, it's simply because they're missing files. And when you're missing your files of what you had for breakfast this morning, or the conversation you had 5 minutes ago, your reality is different than the reality of a person without Alzheimer's, right? So your reality is based on the files that are there, not the files that are missing, right? Versus a person who doesn't have dementia, they have all their files, right? They remember all their memories. And so the most frustrating thing for a loved one or for a caregiver is the fact that they expect their loved ones to have all their files present. And their loved ones with dementia who are missing these files, they're like, what are you talking about? I don't remember that conversation. And then the spouse is like, we just talked about it 5 minutes ago. Didn't you listen? I don't remember it. You know, it's not part of my files. It's been eaten up, you know, by the plaque. It's gone. And so we now have a battle between loved ones. The expectations of somebody who expected their patient, you know, their loved ones who are missing files, they expect it to be there. So the realities are different, completely different realities. When we understand that, we can have more compassion for our loved ones. When we understand that they're just simply missing files, then we approach them differently in the way we communicate to our loved ones. So I wanted to kind of give you that backdrop of how we approach and how we converse with our loved ones with memory loss, with the science behind that.
So in many ways, we're not listening to what they say or what they cannot say. We're listening to their actions and how they present to us. So Mona, as a social worker, there are many tools and assessment modalities that you might use to determine a level of suffering or a level of need in a person who has limited verbal skills. Tell us a little bit about how you would make that assessment and then put it into practice to address their needs.
Yes, okay, thank you, Patty. I really appreciate us all being together and providing this program for the families and caregivers. As we all know, being a caregiver of someone with memory loss is one of the hardest caregiving jobs ever and has one of the greatest stress levels of caregivers. And as many tools and support that you can get, and it's an ongoing learning experience for all of us, both us professionals and the caregivers. I think the most important thing to keep in mind when we're working with loved ones who have memory loss and as professionals is that patients feel pain just like we do. They have feelings just like we do. The challenge is obvious. They cannot express those feelings, those thoughts, and those needs as we do. So I think in social work, back in the day, my first year of social work school, the first thing that we taught, one of our principles when dealing with anyone, is start where the client is. So when I think of someone with dementia and memory loss, as you know, it's very different with every individual. You know, we can provide you with tools and guidelines, but you know your loved one better than anyone else. And those nuances that you know, if you can share those with the doctors and the social workers and the nurses and the staff helping you with your loved one, we need to know that. And it's going to vary from moment to moment. And there are times when you're not going to be really sure what's going on, especially at end of life. But people with memory loss are able to communicate. And I think the doctors might go over some kind of scale that's available that talks about suffering and what we look at when a patient is suffering with memory loss. And I know at some point we're going to be going over that. I think from a social work perspective, we want to understand that our memory loss loved ones can show us how they're feeling through their body language, through their facial expressions, and their agitation. I think their agitation is going to be a little bit different when they're having pain. Even people that are not, don't have memory loss, we can tell when people are in pain through their facial expressions. And that's something people in palliative care and end-of-life specialists, we have that ability to do so. And that's the special training that we have. So it's very important, the facial expressions, and how we interact with people that have memory loss. There's so many things that we can do. We may want to and be able to talk to them. Again, you know your loved ones. So if you know that certain things are going to agitate, if talking creates some agitation, then you're going to pull back from the talking, right? But it's the tone. Even though the person with dementia may not be able to express to us what it is that how they're feeling in response to what we're saying, if they understand anything that we're saying, I think the tone of our voice when you speak in a calm, reassuring, soft voice, and you're doing tactile stimulation. Now again, with COVID, depending on where things are at, if someone's at end of life during COVID, obviously this is just a general framework, but if you're able to touch, if you're able to hug, if you're able, we all know the physical stimulation and touch is very healing. So touch is very important, the tone in the voice. We want to make sure that we're in a room where there's less distractions, there's no lights that might be distracting, music, television. When we're interacting with someone at end of life, if they're having pain, our interaction with them, has that person just been medicated with their pain medication? Because they're not going to be able to respond or react to our interactions if they're having pain. All of this is very important, but it's also very individual for the person. And we're going to rely on you because you know your loved one better than we do. And it's very important that you share with us what you know, and that with our expertise and what we know about general communication, it's very individual, whether a person has dementia or doesn't. End-of-life care is very individual, and our focus is on the patient, our focus is on the family. And at some point, I think we'd like to I'll talk a little bit about what it's like for families that are grieving up until the point when someone is at end of life and what that looks like.
Thank you, Mona. You touched on something that I'd like to have both of our physicians address a little bit. Oftentimes when somebody is at end stage, maybe they're a little bit contracted, they're sleeping a lot, they're sort of minimally responsive to general stimulation. But when care activities are performed, they have to be turned or bathed or change of clothes, or maybe you put them in a sitting position so you can try and feed them a little bit. Generally, that's when a reaction and agitation surfaces. So talk to us a little bit about ways to proactively address that. Should we use a little bit of morphine ahead of care activities? What's your feeling? Both Dr. Nguyen and Dr. Tran. Maybe Dr. Nguyen, you could start.
Sure, let me start in first, and Dr. Tran, please jump in as well. Can I skip the slide that talks on the meaty suffering state examination? Are we able to show that slide to folks? But anyways,
Melissa will bring up the slides.
That's what yes. So next slide, please. So, before we start any treatment plan, we need to start with a comprehensive assessment, or assess as best as we can. So this meaty suffering state examining scale, the last one, that one, yes. is the first objective tool. It's one of the first tools for measuring suffering in patients with advanced dementia. So what it looks like is here you got this 10 items that that the person would check, that the caregiver would check off to see which description best fits the patient's behavior. So as you look at through here, is the patient calm? If they're calm, you give them, if they're not calm, you give them a point. If they're calm, you put a 0. Are they screaming or not? Do they appear to be in pain? Pain here may be in the form of facial grimacing. Do they have a pressure ulcer or decubitus ulcer? Do they have underlying malnutrition? They're not eating, they're not drinking. They have an eating disorder. They have invasive action. That means they're trying to stay away, just like we were trying to do wound care. They don't want to be touched. This is the patient's medical condition unstable. So all these things are this is one of the first scale. And then as you give each score, you add it up. And then if, it's based on low level suffering to intermediate to high, and those are the numbers that you actually get. I find this to be a good start, but it's certainly not the best one out there. But I just want to make sure that people understand there are such tools out there. I like the next toolbox later better. This is the one we're talking about. This is a pain assessment for in advanced dementia scale. So it's called Pain Add. It's a very simple tool to measure suffering for those with advanced dementia. And we start looking at these 5 components. First of all, is look at their breathing, independent of vocalization. So as you look across, when people have labor breathing, long periods of hyperventilation, they're just having a difficult time breathing, that would be a 2. Negative vocalization, it depends on what are they doing. They're calling out, they're screaming, groaning, crying, that's a 2. Or if they're quiet, we'll just let it be. We also look at the facial expression that Mona discussed earlier. Are they smiling? If they're smiling, that means most of the time I don't think they're in pain. But if they look like they're frightened, when we come close to them, they start having facial grimacing. One of the things I do when I assess a patient for pain is I come up to the bed, I knock the bed on purpose. I shake the bed by just kicking on it, and very subtly. If the patients start grimacing, and this is my way of assessing for that. And we look at the body language. Either if they're fidgeting, their fists are clenched, their knees are pulled up. One of the best tools that I've seen with body language for pain is the person, if they can, they pull up into the fetal position, just in a boxing manner. It's like, please don't hit me, don't touch me. That fetal position where they find comfort. And the last piece that we utilize is the ability to console these folks. Can we distract them? Are we able to say things to console them? So we add all these scores up, and so with people scoring anything greater than a 7 out of 10, that means they have pretty severe pain. A 4 or 6 is probably moderate. So this tool I find is not useful to use in a hospital setting, but certainly or an office practice setting. It's more of an office practice. It's not appropriate for that, but certainly long-term care, in assisted living, these are the things that we can train the staff to do and to give that feedback to their physicians. Dr. Trin, what are your thoughts on this?
Yeah, very objective ways to evaluate something that is very subjective, right? Suffering and pain. So these scales are awesome because there can be an action item behind the scores, right?
Mhm.
High pain, low pain, mid pain, high suffering, mild suffering. There can be an action item that can be associated and created behind the scores that's appropriate for the pain level. The one thing I like to point out is that our patients and our loved ones at the end stage of their dementia process, when they are minimally responsive, when they no longer speak or say a few words, and they no longer walk and things of that sort, and they're bedbound, oftentimes society looks at our patients, and sometimes we subconsciously categorize, with or without thinking about it, patients based on what they can do, where they're at. This person's end stage. Let's just, let's focus on this other person who's more active and salvageable and savable and things of that sort. I just want to bring up the fact that no matter what stage we are at in our life, whether we are productive, working, whether we have an education or not, that the intrinsic value of just being human should be respected among all phases of our lives. Whether we're in bed and bedbound and able to communicate or not. My personal view as someone who believes in a personal God, right? That intrinsic value that God loves you, and we should respect who you are, whether you can speak back to us or not. And I think when we think about the topic of compassion, that needs to be brought in. That you're just as valuable, whether you're able to communicate or walk or speak or remember, right? That value does not change, and the approach to our patient should not change because their value is just as important. With that, I wanted to bring that up as well.
And if I could just add to that, I think in general at end of life, physicians in general aren't always comfortable having conversations with patients and loved ones. And when you add the element of a patient that's got memory loss, and that I think makes palliative care physicians, hospice physicians, they've got the training, they've got the understanding and the compassion that you just spoke of. But keep in mind that it's hard enough for some physicians to have conversations with families about their patients, and then you've got a patient that's end stage dementia, that's unable to express themselves, curled up in bed. That's just going to make it more difficult for them, which is why the importance of palliative care and hospice at end of life is so important. And you as a family need to advocate. If an order isn't written for palliative care or hospice and it's something you think is necessary and important or something to consider, even if your loved one isn't quite ready for that, just to have a meeting with a hospice or a palliative care team to understand what to expect in the future is very, very important, because we are trained and we have the skill set to be able to provide you with the tools and know how to assess pain and suffering, when it is the right time to involve palliative care and hospice. And not other clinicians simply don't have the training that we do. It's that simple.
Yeah, so now to answer your question, Patty, the original question's about medications, right? So, the term that I'm going to use today is called, the word is called equi-analgesia. Equi, analgesia, it basically means equivalent pain relief. Every time we think of, when you think of hospice, two big medications jump out at you. People go on morphine and they get Ativan. And there's a reason why morphine and Ativan are used. Not that, we're medicating people to oblivion, but these are common medication that's often used. And every medication that's used, as a geriatrician, we're trained to go low, go slow, but we're going to go. So we start with the lowest dose. And so morphine is the gold standard in pain management. But in the way that I describe morphine and equi-analgesia, is like, think of it as a currency. If morphine is the US dollar, your Dilaudid, your Norco, your Percocet, and others are like different currency, like the euros, the yen, and the pesos or so. So you start with where the patients are at. We don't have problems giving people Tylenol. And then if Tylenol doesn't work, what is the next phase that you go up to? And oftentimes it may mean Norco. And Norco is, we start people with a low dose, like 5/325, which is really hydrocodone. But that 5 milligrams of hydrocodone is equivalent to 5 milligrams of oral morphine. So sometimes if from families and family gets freaked out when the nurses say, we're going to start mom on 5 milligrams of morphine because I've seen so much pain with her. And the families say, nope, no morphine. Morphine is that's associated with the person who's dying and they have to be on a morphine drip and so forth. No, we're not talking about that. We're utilizing the appropriate dose to help the person through the hump. And we talked about earlier today is that, how do people die with with end-stage dementia, they die with inadequate pain control because people don't know, just because, you know, they don't speak and they're not able to tell you I'm in pain, and we underdose. So understand that the principal equianalgesia means, you know, these medications, they have some similarity, but there are, you know, it's not about the name of the medicine, but rather it's the dose. So we always go low, we go slow, but we go.
You touched on something really important that I think does sometimes get missed. As human beings, and especially in Western culture, we are very expressive and responsive to one another, and we take our cues, respond back to us in language, in body language, in sounds, and so forth. And stimulus doesn't always equal response in end-stage dementia. Let's talk about what people who cannot respond are still experiencing. They hear us, they see, they can feel. How do we help families understand what their loved one is experiencing, and then what we can do to make that experience better?
Certainly the sensory perceptions are there. And you're absolutely right. They can still hear us, right? So just because they cannot remember doesn't mean they can't hear. Just because they cannot remember doesn't mean they can't see or taste or smell, right? And one thing I have recommended to a lot of family members is the value of music. The value of music, and I know if you're on this this webinar, you've probably heard of how music can play a significant role in those with dementia, and it's because music enters and processes through the brain in a different pattern or a different pathway than necessarily, you know, where Alzheimer's, the plaque destroys the brain, right? We've seen probably on YouTube videos and other videos where folks who are more advanced in their dementia, they may have not spoken for months or weeks or years to their family member, but you take them to church and you allow them to listen to the old hymns of their childhood, and boom, they wake up and they start singing, and they become alive again, right, during that period of music. And so if you have a loved one who you knew had a favorite musician, a favorite band, a favorite song of their childhood, of their younger years, by all means, right? Even if they cannot speak back or respond, you know, have that going during the day. Get that stimulation. Allow them to recognize and remember those experiences, because music is still intact with that. So those are some ways, some strategies there where you can still connect with your loved ones toward the later phase.
That experiential, and some of the literature really underscores that a musical experience, an experience with fragrance or aroma, can actually elicit a memory of an emotional response. So what other things should families do in order to create an emotional response that comforts the person who might be afraid or who may not understand what's going on?
Yeah, so we could talk about giving, you know, besides music, I think one of the things that you can do is to take away overstimulation for these folks, right? That can cause distractions and cause frustration and them acting out. But again, when we start looking at dementia, we know that our brains are hardwired to words. So we talked about earlier, this can be misleading when we start communicating with people sometimes with the words that we use, because sometimes, you know, people with the Alzheimer's, because their dementia directly involves a part of the brain used to produce and understand language. So we have to look at something else. If we just rely on language and to communicate people with dementia, that's going to be problematic. So
yes,
there, recommendation is if there is a mismatch between words and express emotions, you listen to the emotions. If there is a mismatch between words and action, you look at the action. So it's no longer about words, but utilizing other things, such as music, such as memory, such as fragrance, reducing unnecessary noise and overly hyper-stimulated people.
And I think eye contact, my experience in literature, eye contact is key when you're dealing with people with memory loss, is maintaining that eye contact and being comfortable with silence. I think as a society, we're not really comfortable with silence. And it's very important when just sitting, even people that don't have dementia, that are dying, we have to be comfortable with silence and be comfortable with just sitting and being in that sacred space. And it's okay not to be saying anything, but you've got the music in the background. You may have some aromatherapy. You know, if someone reverts back to their first language, you know, near the end, that happens a lot with and without dementia. So keeping in mind, maybe they need to be spoken to in their first language that they may have reverted back to in the later days of their life. I think it's really important to look at the grief too of the families and loved ones of people with memory loss. You know, as we know, Alzheimer's, dementia, it's such a long trajectory, and that's why it's so hard on caregivers. And we're already anticipating the losses that we know are going to happen, and we're experiencing that grief as they happen. But that doesn't mean that at the end of life, we're still not going to be grieving. I think it's really important not to judge how you're grieving at that time. During the long time frame that you may have experienced, you're doing a lot of your grief. So you may just be cried out by the end. I once had a wife say to me, whose husband had dementia, she said, and he was dying, and she said, "Mona, I'm not crying." And when my friend's husband died in the hospital or on hospice, I don't remember where he was, she cried a lot and I didn't cry. I'm not crying. And I said, "Well, do you normally cry?" She says, "No, Mona, I really don't cry that much." I said, "Well, maybe you're just not someone who cries. Not everybody expresses their grief in the same way." So I think it's really important in the grief that you're experiencing before the death, during the dying process, and after the dying process, is you lean into those feelings, whatever they are. Sometimes those feelings are going to be relief and severe sadness, and they're going to happen simultaneously. You can feel sad and you can feel relieved at the same time. And it's important to try not to feel guilt about feeling some relief, because that relief is going to be there for a lot of people. And you can't get over the grief. So when I talk to people about grief, I imagine it like this big ball right in front of you. It's kind of right there in your way, blocking you. And people, it's so painful. And those of us that have gone through grief know it's like a deep physical pain in your soul. And we want to just get over that ball because no one wants to experience that pain. You can't get over it. You've got to get through it to get to the other side. You've got to slowly get through that. And it's different for everyone. Try not to judge how you're feeling. Just lean into it. Your purpose is going to change. And I think the goal with living after someone you love dies is, how do you find purpose and meaning after someone that you love dies? And if you were a caregiver, most of those hours of the day, even though you may have had a very different relationship with that loved one before the dementia or the Alzheimer's got really bad, you still have a relationship. You are the caregiver. That is how your day was. And when that person's gone, how do you move on? Because your role as caregiver has completely changed. How do you find purpose and how do you find meaning after that? And that's something that you figure out as you go. And there are no answers. It's a journey. A lot of people say, how am I going to get there? And how long is it going to take? And why do I feel this way? And you just lean into it and give yourself the grace to experience it and get the help that you need, whether it be support groups, whether it be counseling, whatever it is that you need, meditation, it's different for everyone. Talking it through, being vulnerable with people you feel safe with, it's different for each of us, but very important to forgive yourself, give yourself grace, don't compare your grief to another person's, and know that you've done a lot of grieving beforehand. So the process after, for some people, is a little bit easier than they thought it would be. For some people, it's harder than they thought it would be. But the point is, whatever it is, and it's you, and it's your grief experience. And don't try to manage it. Just experience it and let it happen. And over time, it sounds very trite and common, but over time, the pain will lessen. And if it doesn't lessen, that's when you really need to think about, going to see someone and figure out what's going on with you if the pain isn't getting any better, because it might be a more complicated grief and you might need extra support through professionals to help you through it.
Thank you, Mona. You brought up a really interesting point about the experience of grief, the experience of fear that the family, the loved one, is going through in the months and weeks or years even leading up to a dementia death. What about what the individual is experiencing, their fear? And sometimes we hear families talk about the fact that the person with dementia might have moments of being lucid, even very late in the disease. And one family recently asked me, how do I respond when my mother says, how do I die?
Good question. Good question. I'm really glad that you brought that up. And I think if during that moment of clarity, when the person asks that question, how do I die? I think it's really important to let that person feel some sense of release and peace. And how you can do that, there's a book written by Dr. Ira Byock, and it's called The 4 Things. And we recommend to families, as their loved one is dying, something that you can say to them as they are dying. It's please forgive me, I forgive you, thank you, and I love you. So when you think about those 4 statements, and he's written a whole book, again, it's Dr. Ira Byock. It's a great book that pretty much covers everything that can happen in a relationship between any 2 individuals, right? Giving that person permission to die, providing them with reassurance. If they've got a faith practice, using that to kind of help them how to frame their experience. I think a lot of it's just giving reassurance. Don't worry, we're going to be okay. When people are dying, they worry about who they're leaving behind. So reassuring them, don't worry, mom, we're all going to be okay. And the reality is, in all honesty, sometimes there is like conflict between family members, and maybe in the back of your mind you're thinking, we're not going to be okay. I'm not really getting ready. We're getting along with my sister. We have so completely different ideas about this. In the back of your mind, you're thinking, there's going to be kind of some stuff going on after this, but you're obviously not going to say that. You're going to say, don't worry, we're all going to be okay. We just give the person permission to go. It's okay for you to go, mom. It's okay for you to be there with dad, or whatever it is that you feel would be appropriate at that time to say based on the dynamics and who's important in their life. Who do you think they're thinking about? Who are they worried about? Who have they always worried about? What child in these group of 6 siblings is the one they always worried about? Don't worry, mom, I'm going to take care of her. She's going to be fine.
And you touch on something really important there too, in giving permission to the person who's dying to go. We are acknowledging that this is a time of transition and that they are dying. And for many people and many cultures, acknowledging that death is actually going to happen is a little bit difficult. So, Dr. Nguyen, do you have a thought about how people can get over that reluctance to actually know that death is coming?
I wish I had a simple tool to help. I mean, there's no magical word, But I think it's more than just words, it's the presence. I think I always remember, this is, well, my mom and dad taught me this, and I remember reading it, reiterated to me, is that it's not, people don't remember what you tell them, but they remember how you make them feel. So it's not necessarily words. Sometimes you're in the midst of that chaos. Sometimes we lose words. I don't know what to say. I feel like, words may come out and it doesn't sound right. So we talk about being silent, just being there, that, I do care. And then as a doctor, I mean, I do hide behind my white coat. And so, whatever I say, it sounds like I'm pontificating. But what I do is I reassure patients and family that, that something I will say that, as doctors, we go into medicine to help people live well and live long. But one of the things we can't give you is immortality. So what's so important, understanding that, is we need to make peace or make friends. When we hear other people say, let's make friends with our dying, let's make friends with our frailty, let's make friends with our humanity, because we are a death-denying society. We don't want to be befriended. There's always a pill for every ill. There's always a next coolest treatment. But we know that all these disease that we have in the 21st century is created by modern medicine. Because in the past, people just die when it's time to die. Now we just help to prolong things a little bit. We kind of delay it. And there's nothing wrong with delay, right? It gives us an opportunity to say what we need to say, to ask for forgiveness, to say, I love you, to accomplish things that need to be accomplished. And one of the things I've learned over the years, and I even learned from my fellows who train with us in palliative care, is using the word time is precious. Whatever time we have now is so precious. Let's make the best of what we got, because we are not going to get it again. So each day we're given a certain amount of minutes. Let's make the best of what we get. It's precious time. And I think it's important to acknowledge within ourselves. And when people put me in a hard people, when this is what I do when I get stuck in a deep in a crisis, is I usually take a deep breath. Everything I do is just breathe. Let's get the oxygen going in my brain. Or at least it gives me a pause to allow me to calm down before I start spattering stuff. Okay, but anyways, those are my thoughts.
Well, you actually touch on something that really is foundationally difficult in a lot of situations, and that's that prolonging the death event. And certain interventions, especially in end-stage dementia, might somewhat prolong that dying period without necessarily improving the outcome or improving the patient's experience. One in particular that becomes a real issue is when the swallowing response is failing and there's this rush to put in a feeding tube. Let's talk about what that means to people with end-stage dementia and why it may not be the right type of intervention.
We can keep a human body alive forever. I mean, I can put down a breathing tube to become your lungs. I can hook you up to a dialysis machine to become your kidneys. I can put you on IV medications to keep your heart pumping and your blood pressure up. And with the technology today, we can actually keep you around much, much longer than maybe sometimes longer than we should, as we psychologically feel, and this is among physicians and patients, this psychological belief that if we just let a patient pass away, we have failed. Right? Medicine is designed to keep you alive for as long as you can. And this is also why it's really difficult to even talk about DNRs. Right? I'm in the emergency room admitting patients every week, and every patient that comes in, there should be a discussion about DNR, right? Do not resuscitate. Do you do it? Do you don't? It is a very difficult discussion, especially among physicians, right? we're hoping it's actually in the chart already, right? So we don't have to bring up that chat. But a discussion that needs to be had, because grandma may not have wanted that breathing tube, right? The dialysis machine and things of that sort to kind of beat the body to stay alive. It's literally what it is for weeks and months. Super important. This other transition we talked about, I mean, there's a transition of discussing, how do I die? The other transition that is an emotional barrier is a transition into hospice or a transition into palliative care. There's this belief that if I put mom or dad or grandma into hospice, I'm letting them die, right? That I'm giving up. And that belief, guys, believe it or not, isn't just among patients. That belief is among physicians.
Yeah.
If I'm going to put my patient in hospice, it meant I gave up, right? And that's a barrier that has been a disservice to our patients. Sometimes we put our patients to a hospice the day before they die, or hours before they die. We're like, okay, let's just do hospice because there's nothing else, right? And that's way too late. That should not be the reason for hospice a day or hours before somebody dies, right? Hospice should be a process of allowing comfort. And hospice is not about giving up and stopping treatment. Hospice is active treatment geared toward, the elimination or minimization of pain, geared toward comfort, geared toward quality during those last weeks or months of your lives, right? It shouldn't be a day before you're dead. And that is an emotional barrier that needs education, and that needs to be overcome among the physicians like myself, right? And the docs around me and the nurses, and this belief that we're giving up if somebody goes to hospice. So definitely.
And I think those are, go ahead, Dr. Nguyen, sorry.
No, please go ahead, Mona.
No, I was just going to say, and what you're speaking about creates a lot of moral distress for those of us that work in palliative care and hospice, because we see other physicians offering a feeding tube to someone who is at the very end stage and probably should be on hospice, and their quality of life is so limited. Their ability to interact with loved ones, their ability to receive their environment has changed dramatically. They're sleeping more, they're experiencing more pain. They're not the same person they were 2 weeks, 3 weeks, a month ago. And a feeding tube is offered. So in most cases, when a doctor says, I'm going to offer this to you, most family members are going to say, well, of course, if it's being offered to me, then it must make sense. So I'm going to say yes. And then it takes us into another pathway of a person on a feeding tube who's not getting better, who's not any more alert, who's still laying in bed and having pain. And then the decision to discontinue those tube feedings is another thing that families are going to have to go through, which is going to create a lot of distress. And we, as palliative care and hospice professionals, sometimes will watch these discussions, and in all honesty, sometimes we're mortified. And we're thinking, I can't believe that's being offered. And the family's finally at a place where maybe they're at peace and ready to let hospice and palliative care come in, and then a feeding tube is offered. And then that grief and that struggle and that ambivalence starts all over again. Just because something's offered doesn't mean it's the right thing to do. Well, and just because it's from a physician, sorry, doctors, if it's just from a physician, doesn't mean it's the right thing to do.
Exactly. Dr. Nguyen, talk to us a little bit about the clinical realities of feeding tubes in stage dementia. Does it really extend life?
Sure. Well, I'm going to Mona and I, we work together. So Mona will see it from that perspective as doctors offering it. But there's also the other side where families demanding it.
Yes.
So the way that I see this is that, yes, as doctors, we make medical decisions. and patients and family to make healthcare decisions. So we can talk about advanced directive later, but let's talk about the tubes. You know, there's more than a dozen studies out there that states that, you know, we do not recommend percutaneous feeding to patients with advanced dementia. But just because we don't recommend it, do we expect these people to starve to death? The answer is no. Instead, we offer oral assisted living, assisted feeding, right? So we know that in advanced dementia, studies have found that feeding tubes do not result in improved survival or the prevention of aspiration pneumonia, because, you know, as dementia progresses, the person loses their ability to swallow. So we think, well, we can bypass this. We'll stick a tube down in their stomach or up in their nose and into their stomach. This will help. It doesn't show to prevent aspiration pneumonia. People still aspirate from the saliva. And they think that, well, we stick a tube in because their loved one has a pressure sore. So maybe when we put in a tube, it'll improve the healing of pressure ulcers. And the studies have shown that feeding tubes used in such patients are actually associated with pressure ulcer development. It's completely the opposite of what we thought. And they go, wow. And it also forces us to use physical and pharmacological restraints. We tie people's wrists down so they don't try to pull their tubes. We give them Haldol, we give them Seroquel, we give them Zyprexa, we give them all sorts of stuff so that we can kind of keep them calm and kind of sedate them so they don't pull it out. But it also, and the patient may distress from the tube itself. You know, people with dementia, they're always, you know, don't know what's going on. They start seeing, what's this thing sticking out of my stomach? I want to get it out. I want to play with it. So what we find though is assistance with oral feeding is an evidence-based approach. It's evidence-based approach to providing nutrition for patients with advanced dementia with feeding problem. And it's in the final phase, you know, in the final phase of the person's life, this assisted feeding should be focused on the human interaction rather than what we call as nutritional goals. We're not interested. So at the end of life, it's not about how much how many cans of Ensure is she eating or how many cans and you can pour down her G tube. It's about the human interaction, because food, it's a social, dining is a social event, so it should be viewed that way. So thank you for allowing me to ask that, because I'm really passionate about this whole G tube. But, you know, when people tell me this, you know, I would explain this to patients and family, but you know, this is, while I don't recommend it, but I also understand that, you know, there's certain cultures where they have to do it. And from my perspective is I would not recommend it. And these are the reasons why.
And in the handouts for today's webinar, there's an infographic that cites many studies that underscore just what Dr. Nguyen has shared with us, that we really don't change outcomes dramatically, and we might actually increase suffering in the process by using certain interventions like feeding tubes or artificial hydration. There's been some questions from our audience. I just want to reiterate the book that I recommended. Someone asked, it's called The Enduring Self in People with Alzheimer's by Dr. Sam Fazio. It's F-A-Z-I-O. And Mona referenced the book by Dr. Ira Byock, spelled B-Y-O-C-K, The 4 Things That Matter Most. Those are 2 of the books that we have discussed here this afternoon. There's been a question about end-stage dementia and whether or not appropriate to continue or discontinue drugs like Namenda and Aricept when somebody reaches a truly final phase of the disease. What's your opinion? Dr. Trin?
Yeah, in the final phase of the disease, when and when I say final, I am referring to someone who's bedbound, someone who no longer ambulates and may not speak back to you when you try to have a conversation. I do not see Namenda or Aricept as having any really significant difference at that phase. Namenda and Aricept plays a good role in the earlier phases of the disease with MCI or with just mild Alzheimer's, when the when we can boost the neurotransmitters and things of that sort in the brain. But what happens is over time, the brain of a patient with Alzheimer's shrink, and it gets smaller and smaller and smaller over time. And as these brain cells slowly go away to a point where our patients are in their final phase, these medications become less effective overall.
Yeah, so I would say the end stage is what it is. You know, that's time for hospice, right? Person is they're unable to have any they don't have a lot of intelligible words. I mean, they may have 1 or 2 words that make sense in a day. You know, they're bed bound, they're incontinent bowel and bladder. These are just really, this is a time in which the medication is no longer beneficial. It makes us feel better that we're crushing this and we're sticking it down our loved one's throat and make them swallow, but it doesn't change anything. They probably put them at risk for adverse side effects and unnecessary cause of aspiration. So I would, when a person before the person reaches stage or when they transition to hospice, these medications I would discontinue for the most part. There's hardly a case in which we continue unless the person, there's some patient that needs to use Aricept to control their behavior, but that's very low. Have you seen that, Dr. Trin, in terms of utilizing Aricept at the end of life? Maybe people claim that it helps with behaviors. And so, okay, if you want to try it, sure. But I have, sometimes we treat families too.
Yes, sometimes we keep the pills on to treat ourselves, not necessarily the benefit of the patient, but we would feel bad if they're no longer on that pill. And yeah.
And just to kind of speak to that, I think when we're at the end of life, we tend to look at it like it's a medical experience, and it's a human experience. And we always feel like we have to be doing something medical. And if a person, I know we're not going to have a lot of time, but if a person hasn't put their wishes in writing, and if we had more time, we could talk about that. What I ask families when they don't know what to do about these interventions, like feeding tubes and like CPR, is I say, if your mom or your dad or your loved one could talk to you right now, what do you think they would say to you if they saw themselves in this state? And then reviewing what it is that's going on with them. What do you think they would say? What would be important to them? What is important to them in their quality of life? What was important to them when they were verbal and having, a different kind of life than they had before the dementia or the Alzheimer's, got really bad. And that helps families kind of go back to what's important and what values this person places on life. And what experiences they had with other dying members of their family and friends. I think that's very, very important. So just because you don't get the verbal response, you have past memories and past statements or behaviors that can give you the answers that you need to have peace in your decision making if things aren't in writing. And even if they are in writing, those past conversations and memories will help you with achieving that level of peace.
That's a really important point, Mona. And part of our discussion today includes the compassion of advanced care planning and why it's such a loving thing to do to talk with family members way upstream before a disease process or an illness or an injury reaches a final stage. But especially in dementia, because it is such a long trajectory, when should we start talking about advanced care planning with people who have a dementia diagnosis? Dr. Nguyen?
I thought you put me in this situation, but I think whenever when we have we always talk about the theoretical, right? When you're older than 18, it's time to have an advanced directive, but in reality, it's not done. It's nice to have, but I think there comes a time when we know that when we're faced with a life-threatening illness, a serious illness in which there's really no cure. I think when we're having a diagnosis of dementia, I really think that's when you need to really sit down with your doctor, and the doctor in the nurses, in social workers. It's really out of professionalism. We should be asking those tough questions. But if we're not doing that, we can reach out to you, Patty, and the team from Alzheimer's there to help us. Is that let's have these conversations, because your brain is still intact. Those amyloid crunches, those viruses aren't attacking your brain to that certain extent yet, but at least you're having this conversation because you're able to express what matters most to you. Understand what the disease may look like, but there's certain things that you can't control. But here's something that you can control, and how you wish to be, how you wish to live whatever time you have left. And most people say, I want to live well and live long. But when I reach that moment, I don't want people to the paramedics come and crack my chest and stick tubes down me and hook me up to machines and send me to the intensive care units with IVs hanging out my neck and a dialysis thing to serve as my kidneys. And these are situations in which we do see. So one of the things that we can help our loved one, because part of this, what we are talking about today, is this language of deep compassion. So this language of deep compassion is about making your advance directives, making your wishes known in advance, not only for yourself, but it's also a loving act to your family, so they don't have to make those decisions to assume this is what you want. But it's also a loving act to your doctors, your nurses too, who's going to have to do this, because in acute crisis, we're not going to have time to ask. We're just going to act. So that's how we're trained. If a person's in a crisis, do things first, ask later, and then we'll figure it out. And unfortunately, there are times in which we do things to patients that would not be according to what's important to them, and they end up on machines. Or worse yet, they're on the last stage of life, and we're doing things to them to make that last moment of their life as miserable a death as possible. So let's prevent that through an advance directive. We talked about this.
Completing advance directives by appropriate use of a document, families can then, in a loving way, understand what someone's wishes might be for care. And it may surprise us. We think that they would want all kinds of interventions done, but then when we actually talk about it, we learn that it's not the case at all, especially once we understand that we can't change the outcome, the inevitability of it. Before we start to close, I wanted to just touch one more moment on the whole notion of comfort feeding. Someone brought something up to me last night about the book, Like Water for Chocolate. It's a book and a really wonderful movie. And in that book, there was a real tie and a real story about how emotions and love and caring get mixed in and season the food that this young woman prepares for her family. And it occurred to me that the way we practice comfort feeding at end of life has a lot of corollaries. Even though we're not living up to the nutritional goals that Dr. Nguyen mentioned, what are some of the most important interactions happen during just a comfort feeding episode? What have you seen, or what would you like to see more of?
I could jump in. I wish that we have more staff to care for these people. I wish that, caregivers, they're doing their best. And this is an unpaid position, right? Because we know that it's very time consuming. It's easier to say, let's do comfort feeding and sit there for an hour and a half and just sit there with, but, if we have enough people, I think that's, I'm just looking at things from a practical event. But if we can, just being able to be present and just being patient. And when I know that when people are living in facilities and there's not adequate staff, and now in the midst of COVID and people are out sick, and one caregiver is caring for 2-3 different patients with dementia, it's very difficult, it's very challenging. But I think, the way I approach this is we have to, we are caring individuals as we journey with loved ones, and we start looking at this as what Dr. Trin talked about before, is we start looking at the person who's sick in front of us, but we look at the intrinsic dignity of a human person and what makes that person human, even though they're in an impaired state, even though they're no longer contributing anything to us. But this is an act of love. We're looking at it from a utilitarian type of calculus, that doesn't make sense. Well, you look at it from a compassion. And this is the work that we do in medicine and palliative care and hospice. It's a work of compassion. And so we just need to slow down and be present and take our own pulse, because sometimes I know it can be very frustrating. And I think what's important here is what we're doing is providing education and providing support. That's how I view this very, comfort feeding, even though we understand the concept, but we also understand the emotional burden that comes with it as well.
And it's really not about how many calories can we get them to ingest. It's about, are they experiencing some tender, loving care with each tiny little bite? And maybe they do have swallowing difficulties. Maybe we do have to be very careful, but you can give them the teeniest bit of ice cream, or the teeniest bit of the meringue from a lemon meringue pie, or just something that gives them that experience and the loving care of the spoon coming to their mouth and you talking to them. So it's experiential without necessarily being caloric. And I think we aren't comfortable with that because we want to be so productive and get that whole egg down them.
And
So
to add really quick, I think sometimes we need to think outside the box and be creative. I had a patient once in the ICU who, those of you that know me, not the best thing I should be drinking, Coke Zero, but it's my vice. And I had a patient who had a stroke and dementia who loved Coke Zero. And he was dying in the ICU. And I just thought to myself, why can't we take one of those mouth swabs, dip it in some Coke, and swab his mouth with it? So I looked at the nurse, I'm like, could we do that? She goes, sure, why not? The pleasure it gave this family to, and I went home and told my daughters at the time, girls, by the way, when mom is ever at that stage, this is what I want you to do. But yeah, just to be creative and try to think outside of the box, I think is really important. The swab and the Coke, it gave the family such pleasure to be able to do that for their dad.
Some little thing that really could make a difference. It's all part of that connection that is physical, auditory, spiritual, tactile, taste, smell. All of these can evoke pleasant and really comforting emotional memory that will flood even a very diseased Alzheimer's brain. I want to ask each of you to share with us a meaningful experience that you had with someone who was at end-stage dementia, something that really resonated for you. So, Dr. Trin, do you have a particular family or patient in mind that stayed with you?
I do. And I think of that person now today because I actually just saw that person not too long ago in the office. And this person was somebody who worked with me, who was in the healthcare field, who, we were colleagues. And I saw her during her prime when we were working together and chatted together and did projects together. And now she doesn't know my name, but I still see her, and her husband brings her by. And what I've done and what we've done was we would bring a group of nurses together and to spend time with her, people that she would recognize, and it's watching up front, not as a physician to a patient, but watching up front somebody you care about go through this process, and seeing that process just slowly, the slow dwindle of her mind over time. It helps you to recognize that it's not just about taking more pills or brain scans or IV infusions and all the technology we can throw at a person, but it's really just holding someone's hand through this process and just to care for them and love them and to treat them for who they are as a person and to value them for who they are even as they go through this process. And it's taught me a lot than just being a doctor to a patient. Yeah.
Thank you. Mona, do you have a particularly meaningful experience with a patient when you knew that your interventions were really making a difference for them?
I don't know if I can top that story. Wow, that was pretty meaningful. Yeah, I do have a story, and this is a patient that I didn't know before. I didn't meet them until they were in the ICU dying. So this was a woman who was 77, and she had moderate dementia, and she actually had a stroke. She was walking with one of her family members and actually just fell. I think they were walking to lunch or dinner, and she fell. Came into the ICU, and it was very clear after a short period of time that things were not going to change. And the two daughters were very ready to let their mom go. You know, there was no feeding tubes introduced or asked for. She wasn't on a ventilator, but she was dying. It was clear that she was dying. And she wasn't speaking, she wasn't verbal, and I was to come in to talk to the family and give them some support. I'd never met them. I walked into the room, introduced myself, and within 20 minutes, the patient opened her eyes, looked around the room, and her voice was not very strong. It was weak, and you had to really listen to her. And she looked at her daughters and said, "I love you. You mean so much to me." I will never forget that moment as long as I live. The look in their eyes and their response, and it was almost like they didn't believe it was happening, and they both looked at me and they go, did this just really happen? And I said, yes. And they started talking to her about the legacy that she was going to leave behind and all the things that she taught them. And she ended up staying awake for probably 10 minutes and then slowly just got sleepy, closed her eyes, and never woke again. And the bond that I developed with these two daughters based on that 10 minutes. So in the work that we do, we can bond and connect with people so quickly because we're in this sacred space, and it was such an honor to be part of that. And the whole legacy discussion was just beautiful to watch, and they shared some very personal things and talked about her, and I felt like in that short time I got to really know her and understand the relationship, the mother-daughter relationship that they each had with her. It was beautiful. It was beautiful. I mean, that moment may not have happened, but it did, and I think it just made the whole process of her dying so much more beautiful and meaningful. And dying can be beautiful and meaningful. It really can.
Absolutely. Dr. Nguyen, tell us about something very meaningful for you.
In my career, I've attended and have cared for many, many patients, and I can tell you more often than not, patients and family, people with dementia with their loved one. I mean, patients die very peacefully. There is peacemaking, but but somehow for me, the things that stick out most are the ones that didn't work as well as it should. We talk about care for people with dementia, but the problem with medicine and what families sometimes ask us is this reflexive use of all available technologies to prolong life. And we have handful of patients that stick with me is I come from with my last name and with my black hair, and so I'm Vietnamese. So oftentimes, my physician colleagues will say, Vince, why don't you go and talk to this Vietnamese family? Let's talk to them. They have end-stage dementia. Let's talk about tubes and how it's inappropriate for us to continue to do treatments that's not prolonging their life, but really prolonging the dying process. So maybe you can help and sit and talk with them. So I said, I'm no miracle worker, but okay, I'll go and sit there. And despite using the best tool and being so compassionate, I can relate with them from our culture and explaining everything. But I understand, but there are times in which where the family comes back to me and said, thank you very much, Dr. Nguyen, but we're not giving up. They insist that everything needs to be done, everything, so that even though there's little chance of recovery, but as long as there's treatment, we want it all. And of course, the person and that patient's up in the intensive care unit with a breathing tube in their throat, central lines in their neck, a dialysis machine. And I recognize at that moment is, even though it was a failure from me to convince the family. But I have to look back and say, look, I've done everything I can as a physician to explain. But each person, the family and the patient, they have their own journey. They have their own history. Even though I may not agree with it, maybe the medical team may not agree with this. But sometimes for those families and for those patients, they have to go through that themselves before they understand, before they finally understand that that's right, they have done everything they can. So those cases stuck with me. So it's not like, you know, get palliative care involved, you're gonna go and solve the world and everything, or no one will get feeding tubes and everything will just die with each other, you know, with loved ones holding their hand and kumbaya. But there are times when their loved ones will die in intensive care units. And I just need, I reconcile and say, I have done everything I can. And those patients and family need to go through that journey. But that would be not the journey that I would choose for myself, but it's theirs.
Thank you. Well, we're coming to the end of our time together. I think what it says to me is that there's a lot more that we could discuss, and perhaps the next time we would want to really delve into some of the people involved in 11th hour vigil techniques and ways that we can give practical as well as very theoretical kinds of help to families and to professional caregivers to support people who cannot verbalize what they're going through, but are still experiencing perhaps a significant amount of suffering, how we can effectively assess for it, how we can address it in the most loving and kind and responsive way possible, and how we all are touched by their suffering. And that in order to really address and mitigate suffering, we have to have experienced it ourselves, much like the really notable author Henry Nouwen talks about as being a wounded healer. We have to be open to suffering in order to recognize it and then try to heal it in others. So we'll work on that, on having something the next time talk about vigiling techniques and more about the sacred space. I believe we have answered most of the questions that have come up. One in particular is that, yes, it is a good assumption that people at end-stage dementia do have some suffering, and that it's very important to assess it appropriately and to take matters. And would each of you like to have a closing comment as we wind up this afternoon with our guests? Mona, would you like to start?
Yes. So I would like to quote Dame Cicely Saunders. She was the founders of St. Christopher's Hospice in London, England, and her words and statements are kind of known to most people that work in hospice and palliative care. So I'm going to quote, I'm going to read the quote. You matter because you are you. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but to live until you die. How people die remains in the memories of those who live on.
Beautiful. Thank you. Thank you, Mona. Dr. Trin?
I don't have a specific quote, but I do have just a quick statement that healthcare is more than treating an organ. Healthcare is more than treating a lab or an X-ray. And so complete total healthcare is addressing the physical, the emotional, and the spiritual as well. And that's what we should strive to address, the whole person, and especially toward their end of life.
Wonderful. Thank you, Dr. Trin. Dr. Nguyen?
Amen.
Amen. Thank you so much for us, wonderful guests. We also want to thank Care Choices Hospice and O'Connor Mortuary, because with their support, we're able to bring you these really wonderful programs out into the community. And I think we have our work set out for us on how we can expand on the discussion here today. For those of you who have asked for contact information of our speakers and provide that too, you may want to send us email or contact me, and we'll provide you with information of how to connect with our speakers this afternoon. Thank you to all three of you. You have added a real richness to our understanding of the importance of the sacred time and this not just practical, theoretical, spiritual, tactile, and really heart-centered loving care that brings us deep compassion at the end of life. Thank you. Have a wonderful afternoon.
Thank you. Thanks, Patty. Thank you for putting this all together. Thank you.
My pleasure.
Bye.